you. Afternoon, everyone. So you can see the title there, the passenger brings a passenger, tail fails. And the story, as many others do, started off in the lab. A couple of months ago, one of the technologists came to me after working the previous weekend. It was on Monday, and she said she's got a wet prep of a stool specimen. And it's a bit odd. She's pretty sure she sees parasites, but the amount seemed quite unusual. And something about it was, and I quote, giving sus, which is GNC for making her suspicious. So I just wanted to have a look at it, and you speak to fluent energy. Usually don't have to ask me twice to go look for a parasite. On the form, it said just diarrhea. It came from one of the peripheral hospitals. So I got the specimen, and this was on the very first field. This is what I saw. Synchronized. So all those orangey, dark, long thingies, that's all parasitic larvae. So as I was looking through, this is just another.
Can you say what?
Another view, and just everywhere I looked, the entire slide looked like this. Must have been like hundreds and hundreds of them. So for us, if we see larvae in the stool, usually it suggests Strongyloides. But typically you only find one or two per slide. And that's mostly because the larvae get shed quite intermittently, and depending on your burden, usually you see between a few dozen and a few hundred being shed in your entire spool volume over a 24 period. So seeing this many is definitely unusual, and I had to agree it was giving sus. So for us, one of the most important lab mimics of Strongyloides, and something that we have to consider, is hookworm larvae. But to see hookworm larvae in the stool, usually there's quite a significant delay between specimen collection and us receiving it in the lab and processing it. Because with hookworm infection, you excrete the eggs and not the larvae. And in the soil, in the environment, if you've got favorable conditions, they will then hatch in 2 to 3 days, and the larvae will emerge. So theoretically, if a stool sample is left on a windowsill or in a sunny spot, they can hatch in the specimen. And if you get it only a couple of days later and you look at microscopy, it's going to look very similar, almost identical. And then in order to differentiate between those two, which one you're seeing, you need to look a bit closer, and there's a few key morphological differences. And basically, if you look at the left there, the first thing that Strongyloides has is a short buccal cavity. So the front there's the head, and you can see in the middle there's almost like a little canal-ish kind of line down there. So that is short. Where hookworm is longer. It's difficult if you haven't seen both or you don't have both to compare, but that is what the short one looks like. The second feature is genital primordium that's quite prominent in Strongyloides, which is that kind of thing that you see in the middle there. So that represents, that's usually what develops into the reproductive organs as the larvae mature into adults. And the third, which is probably the most definitive difference, is seeing that notched tail. So that is unique to Strongyloides, and that actually represents the mature infective form of the larvae, the falciform larvae. Under normal circumstances, we don't really see it. It's actually very rare to see them on a normal stool microscopy. But on this guy, so this is from his sample, and there were lots and lots of it. So next, I saw some other results that were available on the system. There was a CD4 count of 30, it was very negative. His electrolytes were quite abnormal, and there was a significant lysocytopenia, white cell count. Hemoglobin was low. And then we can also see, if you look through the older results, you can see which diagnostic or which diagnosis has been written on previous request form. And from a month ago, there was this diagnosis of typical pneumonia. So I managed to get hold of one of the doctors that work at the referral hospital that he was currently admitted in, and he gave me a little bit of information, still pretty scanty. He said that this is a 47-year-old male with advanced HIV, was admitted with diarrhea and was quite dehydrated when he got there. Appeared chronically ill and was a little bit confused, but overall not really too worried about him, was clinically stable. He was getting IV fluids because dehydration from diarrhea, and the pharmacy didn't have ivermectin, so they started albendazole. So, in discussion with Priya and the IT team, to try and facilitate urgent access to ivermectin and to get a bit more comprehensive clinical assessment and review by the infectious disease team, we were then further across to Steve. And when he got here, gradually the kind of full story became a little bit more clear. So he was from Malawi originally, but he hadn't been back in over 10 years. He was recently incarcerated in December, and early January developed some respiratory syndrome or symptoms in prison, and he was referred to this referral for the hospital, and the diagnosis of atypical pneumonia was made, as well as newly diagnosed HIV. They excluded TB, treated him with ceftriaxone, and then got a little bit better, and he went back to prison, and somewhere in between started on ART. But he had diarrhea already actually on discharge, and back in prison it just got progressively worse, and he was just kind of getting more and more unwell over the course of a couple of weeks. And then towards the end of February was rediscussed and then sent across to the regional hospital, which is where the stool sample was sent to us from. On presentation here, he was thin, very chronically ill looking, very pale. Didn't really seem confused. He was able to engage and answer some specific questions, but did seem a bit blunted. He had ongoing diarrhea, generally very weak. He had significant abdominal distension and quite tender globally on his abdomen, and he had terminal neck stiffness. And another thing that he actually volunteered was this severe pruritus, particularly over his lower back, which had been going on for weeks. And when I looked at his abdomen, you could actually see the scratch marks from just because it was so itchy. We also had this non-specific kind of papular looking rash, which was later described to be probably PPE of advanced HIV, but worth noting. The blood results on arrival here, his electrolytes, it's a little bit better, but his urea basically doubled, and his hemoglobin at 3.0. A differential count was done, and you can see there's significant lymphopenia, and of note there's this eosinophil count, which was 0.01, which is almost 0, which in a general parasitic infection seems not like something you would expect.
So is that his about 0.5?
It's 0.0.
Oh, 0.05.
We'll go back to that. So he had some imaging done. This is the report of his CT chest and abdomen. They reported on diffuse miliary pulmonary nodules and this ground glass kind of changes. They thought radiologically most in keeping with miliary TB. It also just started on ART. And then in the GIT, he had this mural thickening that extended through from the stomach all the way through, basically, with features of ileus, but luckily there's no overt perforation that they could see. That was the X-ray on the left there, which is not normal, and you can appreciate the extended bowel that this was on the abdominal X-ray. So before you look there, he was then reviewed by the infectious disease team, and they shared the concern that his presentation might represent something more than just an uncomplicated intestinal strongyloides. But there's also obviously a high likelihood of an unmasking opportunistic infection since he just started ART, and that could be contributing to his illness. So plan in C15 at that point was to do a lumbar puncture because he had was meningitic, and he was also started on TB treatment as well as iris cataract while waiting the LP results. So I'm going to just pause there with the case for now, and I want to just tell you a bit about what makes Strongyloides unique amongst the intestinal nematodes and why finding it should cause concern and trigger some further investigation and evaluation. So, Strongyloides, I'm going to try and be brief about the general things. It's found predominantly in tropical and subtropical regions, much like the other soil transmitted elements, including sub-Saharan Africa. The prevalence, don't really know what the true prevalence is, but estimates are in the hundreds of millions, depending on where you read. But it's probably still a substantial underestimate because it's really so difficult to diagnose low burden infection. Many things that there are many things about this organism that's really fascinating, so I'm going to try to stick to the relevant ones. But forgive me if I go off script a bit. But what makes this nematode really stand out from the others is its unusually versatile life cycle. So in humans, are the primary definitive host. The adult parasitic female is the one that reproduces by parthenogenesis, which means that there's no male needed for fertilization. And actually, in fact, adult male wombs are never seen in humans. They're only seen in nature and environment. Then the second thing is, instead of passing eggs like the other soil transmitted elements, the larvae are they hatch within the intestinal mucosa of the small bowel, and then they're passed as the deformed larvae, which is the immature form. And then they end up in the environment, and then in the soil, if the conditions are favorable, they will then transform or molt over a course of 2 to 3 days until they reach the effective form, which is the filariform larvae, which is that one I showed you earlier with the fourth tail. And those filariform larvae are really highly active, and they've evolved specialized adaptations to seek a host to reinfect in the most efficacious way. And one of the things they do, which is similar to ticks, the questing behavior of ticks, is they find a bit higher ground, typically it's a blade of grass or a leaf or something, and then they display this behavior called mutation, where they will raise the anterior part of their body, and then their head is at the top there, and then they start sensing, surveying the area. And they are very strongly attracted to body heat and to certain compounds that we release in our skin and in our sweat. And once they've sensed that, they are locked in. Once there is physical contact with human skin, then they become activated basically, and then they rapidly start burrowing into the skin, and that's where the cycle in the human starts. Then, as I mentioned earlier, there is also a free living cycle. So some of these reptiform larvae that will get excreted in stool won't transform directly into filariform larvae, but they will form into the L2, then L3, and then become adults in the environment, and then complete the full cycle without needing a host like a human. But the cycle that is most relevant to this case is actually the ability of them to have an auto-infective cycle. And basically, so the reptiform larvae that hatch within the intestine, most of them will pass in the stool, but a small proportion of them will undergo a more rapid transformation within the gut, and they will become the filariform infective larvae while they're still in the intestine. And then they can then penetrate the intestinal mucosa all around the perianal skin. Then they will migrate through the host vasculature to the lungs, up the trachea, back down into the small bowel, and become adults there again. So theoretically, a single larval exposure years ago, if it makes it through the migration phase, can result in this chronic infection that can last for decades and almost the rest of your life, depending on how old you are when you get it. So thinking back in our case, this patient most likely got it in Malawi, which was more than 10 years ago, and he had been pretty much asymptomatic with a low burden infection. So to understand what changes from having this chronic, mostly asymptomatic infection for decades to having all of a sudden a fulminant, overwhelming parasite burden, it's important to just understand how in normal chronic strongyloides, how does the immune system actually control it. So in an immunocompetent individual, your eosinophils usually will trigger a very specific Th2 response. And that in turn releases certain signaling molecules like IL-4, 5, and 13, and together they will boost your IgE production and further recruit more eosinophils to actively attack and kill the larvae that are in the intestinal lumen. And they also increase mucus production in the intestine, and that kind of acts as a form of trapping the larvae that are in the, like, free swimming in the gut. And it also increases intestinal motility. So you then trap them in this mucousy layer and you just get rid of them pretty quickly. So this response doesn't eradicate strongyloides, but they keep the overall parasite burden pretty low and at a stable level that persists for decades, as long as your immune system keeps that Th2 response constant. So there are several clinical settings that can destabilize this balance, and some of the best described risk factors include HTLV1 infection, transplantation, hematological malignancies, and other forms of immunosuppression. But probably the most important and consistent trigger is corticosteroid exposure. And the effects of that can occur really rapidly, even after quite a short course of corticosteroids, and not really reliably predicted by the dose or the route. What they do is they suppress the Th2 response, steroids, and they produce this profound eosinopenia that impairs eosinophil-mediated larval killing. They also reduce the IgE and mast cell activity, and then weaken the mucus production, slows down gut motility. So these larvae then have a longer time to try and mature before they get expelled eventually. In addition to that, corticosteroids share a very similar molecule to the natural, like, molting and reproductive hormone that the worm has. So steroids actually can bind directly to certain receptors, and they stimulate the females to produce more eggs than usual, and they trigger the larvae to molt and transform at a much faster rate. So together, it's kind of the perfect storm, and this results in a grossly exaggerated autoinfection cycle. You have an explosive increase in your larval burden, and that's along your normal gut-lung migration route, and that is what's called hyperinfection syndrome. So disseminated strongyloiditis is a distinct diagnosis, although they frequently coexist. But that usually occurs when larvae migrate beyond that normal gut-lung axis and to ectopic sites, and typically includes the skin, the CNS, or the hepatobiliary tract. And the thing about both these syndromes is they carry a really high case fatality rate, and mortality in untreated severe disease can reach up to 90%. So it really is something that should be recognized. So that's all that larvae all of a sudden they accelerated autoinfection, this hyperinfection syndrome. So in hyperinfection syndrome, there's basically two overlapping mechanisms that cause this severe kind of presentation. And the first one is direct larval injury. And that's due to this enormous amount of larvae that are kind of simultaneously migrating through the tissue. So in the gut, you get intestinal inflammation, diarrhea, abdominal pain, present with ileus, and sometimes they have bleeding. And in the lungs, typically it causes a pneumonitis and severe alveolar injury. Because as they go through the alveolar capillaries, they kind of burst through them to get into the alveoli. So you can imagine if there are thousands of them doing it at the same time, it can result in hypoxemia and potentially respiratory failure. And then the second kind of simultaneous mechanism, and it's often the one that ultimately leads to death in patients, is enteric bacterial invasion. So it's mostly because of your severe intestinal tissue damage. Your enteric bacteria can translocate across these disrupted mucosa and lead to gram-negative bacteremia and metastatic infections, including secondary meningitis. And another thing that they do is that they often physically attach to the cuticle of the larvae. So cuticle is kind of sheath that it has on the outside. So they can hitch a ride on there, or they can be inside the intestinal tract of the actual larvae and journey through them or with them as they go on their migration, and then cause distant site infections. It's difficult to diagnose disseminated infection because you actually need to find the larvae in an ectopic site. I quickly wanted to touch on diagnosis. So for hyperinfection, it's usually quite easy to pick up with general microscopy. Where was I? So there's usually, because there's so many motile larvae, it's pretty easy to spot from either stool sample or even respiratory samples. So molecular tests or serology is usually not needed and often not helpful in the context of immunosuppression. And obviously has a longer turnaround time, and this is something you want to diagnose and treat as fast as you can. In the uncomplicated and chronic infection side, because the parasite burden is so low and intermittent, stool microscopy is very insensitive. So even with concentration methods or serial stool microscopy, the sensitivity is only around 50 to 60%. So that's where serology is really generally quite helpful. And depending on what assay you use, sensitivity is up to around 90% and specificity around 95%, but can vary a bit between populations, and there is some cross-reactivity with other elements. But a really important opportunity to diagnose this chronic, uncomplicated form of the disease is before planned immunosuppression, if you have the luxury of planning it, if someone needs a transplant or something. So depending on the center and wherever you work, they've got different screening protocols, but essentially they want to try and establish who's at risk from an epidemiological point of view, which can be difficult because it could have been infected 60, 50 years ago. So the most reliable thing that they use, similar to chronic uncomplicated disease, is serology. They often combine that with serial stool microscopy or molecular methods. In some settings where serology is not really readily available, or the cost and the turnaround time make it a bit more impractical, they'll often just treat with a single dose of ivermectin in someone that they think is at high risk. One of the concentration methods that is specific for Strongyloides is called the Bierman technique. And basically what you do is you suspend a piece or amount of the stool in like a tea cloth permeable thing, and you surround it with
It's kind of muscle.
that's it. You add some lukewarm water around it, and then you kind of anyways, you allow the
Leach out.
yes. That's the word I'm looking for.
Incubate.
No, well, because they're attracted to heat, they will try and migrate out of there to try and get to the hot water. But because they're heavy and they're not great swimmers, they will sink to the bottom, and then from the bottom you can take your sample and you should see it there. Another thing is to use an agar plate culture. So you take a bit of the specimen, whether it's stool or sputum, you just plate it there and you incubate it, and after a couple of days you might see those tracks as the larvae are migrating and carry the bacteria with them, just like the which I wish we did with this patient. But anyways, the treatment guidelines pretty straightforward for uncomplicated strongyloiditis. First line therapy is ivermectin, usually for 1 to 2 days. Sometimes they'll repeat it after 2 weeks. Albendazole is an inferior agent, but it is a recognized alternative regimen if you don't have access to ivermectin, which a lot of people don't have. In hyperinfection and disseminated strongyloiditis, becomes more important. That's a medical emergency. So your approach basically is, if you can, try and suppress or decrease the immune suppression, and then start ivermectin, which you would give every day, and you'll continue this for as long as you need to, until both the stool and respiratory specimens remain consistently negative for at least 2 weeks, which can take quite a while. So if a patient is really sick or they've developed an ileus or malabsorption, another option is to use rectal ivermectin, which has been used successfully before. And if you really are at the end of the line, can't even use rectal ivermectin, there are subcutaneous formulations available, but they're only approved in veterinary use. But through, I don't know what things you have to go through to try and get that, but that has been done before, and as a last resort has some effectiveness. Then, of course, the last thing, which is to importantly recognize and treat gram-negative sepsis if it's there. So back to our patient quickly. So his LP results came out, and you can see he had abnormal biochemistry in cells. Glucose was less than 0.1, almost 3,000 polys. This was his gram stain. You can see gram-negative bacilli, quite a lot of them. The next day on the plates, this is a very juicy lactose fermenter, which we identified as Klebsiella, which is wild type susceptible to ceftriaxone, which he had been started on. Unfortunately, he actually passed away that previous night already. I think by that point, the tissue damage and overwhelming gram-negative sepsis was just too much. So, thinking back in terms of what triggered the hyperinfection syndrome in him, we still weren't really sure. What I was suspecting was that he may have received corticosteroids, the most likely thing, especially given that a month ago he had this respiratory syndrome. Although it's not noted that he got steroids from the hospital, I know that there is a medical facility in the Polsborough, so it may have gotten from someone. We couldn't determine it definitively, but the other thing to note is that HIV, even advanced HIV with immunosuppression, isn't a classic trigger for hyperinfection. It used to be one of the AIDS-defined illnesses, but they realized that with HIV, even advanced disease, your Th2 specific response is still generally quite intact. So they're not really a typical risk for hyperinfection syndrome, just based on HIV. So then what I wanted to just end off with is this message that I want to highlight specifically with this case, is that in hyperinfection syndrome, it's not really any single finding that will give it away or make you think of it, but it's recognizing the pattern and anticipating complications. So in this guy, he had this remote exposure that remained relevant decades later. He had an extraordinary larval burden, lots of filariform larvae, which you usually see in hyperinfection syndrome. He had a combination of gastrointestinal and respiratory symptoms, which obviously could be ascribed to many things. Also had confusion with neck stiffness. Then the severe pruritus could have been due to larval occurrence, and ultimately gram-negative sepsis and meningitis. Remember, our patient had the low eosinophil count, so if you see that, it doesn't exclude severe strongyloiditis. Think of pathogenesis. In fact, eosinopenia is actually a direct contributing factor to developing hyperinfections.